I am going to get us started roughly on time because we have a lot of people watching this on live stream. So I want to keep us on schedule since those people are at their computers all over the world. So welcome everybody. Thank you all for joining us here in person in Geneva, as well as wherever you are all over the world. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health, and on behalf of our school, welcome to today's event. This event is co-hosted specifically in coincident with the World Health Assembly, and it is really part, though, of a series of events that we organize at our school that are intended to put a spotlight on what matters most for health. We do these events to encourage debate and discussion in multiple different formats, some in person, some hybrid, to sharpen how we think about health, trying to see a way of moving forward in health through conversation. Now, today's event is co-hosted with the Alliance for Health Policy and Systems Research, with gratitude to them. And I'm delighted to have you all here, both in person who are part of the World Health Assembly principally, and those who are on Zoom. What we are going to do today is we're going to talk about something which I feel like has been discussed quite a bit in the academic literature in the past 25 years, has seeped into the public conversation, social determinants of health. But I think that conversation has not been as centered around what it means to think about social determinants of health, what it means to measure social determinants of health, and more importantly, what does it mean to think about social determinants so that we can act on them towards making better decision-making that promotes health. The idea here is that you're going to hear from Dr. Salma Abdallah, who will introduce in a second, and then you're going to hear from a panel of speakers who each bring different country, different national, and different perspectives on the question of how do we think about social determinants so that we can set up the stage to act on them to make better decisions to promote health. Today's panel emerges, as you'll hear shortly, from the Rockefeller Boston University 3D Commission that originally articulated the need for global data to assess social determinants of health. And what we're going to do today is, in the presentation, talk about how that work has evolved into a systemic, standardized approach to measuring social determinants that we hope will pave the way for greater global energy and global synergy around measuring social determinants to improve health. I'm going to ask our first speaker to come on, Dr. Naveen Rao. Dr. Rao is with the Rockefeller Foundation and was one of the original architects of the 3D Commission as partnership between Rockefeller Foundation and Boston University School of Public Health. Naveen.
Good evening. It's late in the day, so I'm going to be as lively and as brief as possible. What Sandro forgot to mention that he and I built this at a very, very fancy coffee shop called Starbucks here at World Health Assembly 2019, just before the COVID hit. So for us to come back here 5 years later to talk about it is personally very satisfying. And I remember the concept when we were starting out, and it hasn't changed, but when we say health, most people go to healthcare. When we talk about health, people just start seeing doctors, medicines, hospitals, and that is healthcare. What is amazing is 80% of your health depends on the food you eat, the air you breathe, where you live, and that is health. 20% depends on healthcare, the doctors. By then it's too late, but if you're seeing doctors, right? But 90% of investments and all the talk is on the healthcare side. Only 10% goes to health. So there's really that 80-20 rule where 80% of your health depends on the social determinants and only 20% on healthcare, but we spend more time here than on that. Then the question is, as we're getting better, technology is getting better, we've got better at fishing bodies out of the river, but the question is who's throwing them in? And it's the social determinants of health, and I'm really very proud that we work together on this. And if you look at even today, take a pregnant woman in Dhaka in Bangladesh, she's pregnant and she's drinking salinated water because of rising sea levels. That salinated water is giving her hypertension, preeclampsia, eclampsia, and then with the heat, she's having kidney disease. She has to work outdoors. So for no fault of hers, she did nothing to contribute to the carbon crisis and where we are, but she's suffering the most. So this 3D commission, what can we do to formalize it? As Sandra said, how can we make it accountable, put teeth in it, get it into policy, get it into advocacy? I mean, we should be demanding more. And I think this is a great start. I personally am very proud to be part of this story and the 3D Commission. I think the work has just begun. So back to you, Sandra. Thank you for the opportunity.
Thank you, Naveen. So now I'm going to ask Dr. Selma Abdallah, who's an assistant professor at Boston University School of Public Health, who's going to do an overview of the path from the 3D Commission to the data at the Global Social Determinants of Health Survey. Selma.
Thank you. Can you hear me?
Yes.
Okay, great. Yeah, usually there is an issue with either it's too long or I'm too short. I'm not sure which is the case, but I'm assuming today actually I have this set up, so it should not be a problem. But yeah, as Sandra said, we're really happy that you're all here with us today, and thank you very much for joining us either on Zoom or in person. We appreciate it, and we know that there are a lot of events that compete with this event, so thank you for choosing to be here with us. For my presentation today, I will provide an overview of the work that we did on data on the social determinants of health to inform decision making, and then I will present some of the examples from the recent survey that we conducted on the global social determinants of health. Now, I think it's not foreign for most of us who are here in the room that our understanding that the role of social and economic factors, what we collectively call the social determinants of health, the role that it plays in shaping our health and outcomes, either on the individual level or the population level, that is not a new concept. We're all aware of it. However, the concept has really gained prominence and eminence in the public health field, along with among governments over the past few decades. And here I highlight a few good publications, I think, at least to my mind and to the students who are watching. If you're interested in social determinants of health, I would highly recommend reading those, starting with the groundbreaking World Health Organization report in 2008. But despite this growing recognition, and I might even say from attending a lot of meetings recently, despite the truism that everyone says at the starting of the meeting, yes, we know social determinants of health matter, but then focus on healthcare, that we're not really focusing on how we translate our knowledge of the social determinants of health into action on the social determinants of health. Now, at the same time that there has been growing recognition of the social determinants of health, something else was happening in the tech sector, where we were discovering a lot of technologies that led to the development of a lot of data with far more granularity than ever expected before. So based on that understanding that we can combine progress in the field of social determinants of health as well as in the field of data science, we convened the 3D Commission that was led by Rockefeller Foundation and Boston University, with the hope that we can use the two fields to actually inform decision making on health. As you can see here from the slide, the Commission aimed to achieve its global goal by really combining global experts from everywhere across the globe to try to find experts that focus on determinants of health, experts that also part of the data science sphere, but also decision makers from the local to the global level. Now, the 3D Commission focused on examining barriers to action when it comes to social determinants of health, and published in 2021 its recommendations and principles on how we can move the field forward. One of the barriers the 3D Commission identified was that we have a lot of challenges in finding data that are not scattered or highly identifiable on the individual level, and that allows researchers or decision makers to actually be able to access data on the social determinants of health. Now, knowing this, we developed a website that aimed to provide relevant data for all stakeholders that are interested in social determinants of health, that provided a repository of national and international data sets that you can all access if you go to this link. Of course, the repository is not a complete list, so if you go online and you find that there is a really helpful data set that is not available there, please email us and we will add it to the list. Also, when we examine the sources that we added to the repository, we noticed that there are other challenges when it comes to data on social determinants of health. One of the most important challenges that we need to address in the upcoming few years is the fact that there are stark differences between the level of data we have in different regions in the world. For example, in the first iteration of the data repository, we found 17 data sets that allow us to use individual level data in the United States, compared to only 12 data sets across the 54 countries in Africa. And an additional challenge we also found is that even within the existing data sources that we have, those data usually lack standardization. So this is a word cloud that highlighted all the data sources that we found. And if you look at it, you will see that we have some comparable figures, but they're not, or measures, but they're not really that comparable to the point that would be standardized and help us look into the available data across countries. Now, motivated by those findings and by the work of the 3D Commission, we then launched the Global Social Determinants of Health survey. The survey was intended to gain insights about the role of social determinants of health across a diverse set of countries. But at the same time, we also hope that we would serve as a proof of concept that we can collect standardized data routinely to inform our decision making when it comes to social determinants of health. The survey was deployed by EPSOS, so we worked with teams on the ground in 8 countries, including Brazil, France, India, Indonesia, Nigeria, Turkey, the Philippines, and the US. And the survey collected data from 8,300 people. Now, to develop our survey, we used the socio-ecological model, which is now a standardized model that was adopted from the WHO report on the social determinants of health. We used this model because we wanted to create a standardized list that others can use later if they would like to. The survey questions ranged from institutional trust, social cohesion and social support, experiences of discrimination, level of income and assets, debts, adequacy of access to resources, including healthcare and food, as well as stressors, traumatic events, and mental health outcomes. I will then now present a few examples of the results that we found from our survey. Just to note that this list is not comprehensive and that it's not the most striking results that we found in our survey, but rather they're just examples to show that without regular data collection of social determinants of health, we will be limited in our ability to actually have decision making that is informed by data. So first, I will present a few examples on what we usually call as core assets when it comes to the social determinants of health. And those are usually the assets that we think about when we think about social determinants of health. So those are usually income, financial situation, and food insecurity. I will then present how those core assets influence other assets, such as optimism and trust in government, as well as mechanisms through which social determinants of health can act on health outcomes. So for the first example, we included several questions that tried to look into social cohesion within countries. For this example here, I'm showing the results for a question when we asked people, do you think your neighborhood is a close-knit neighborhood and unified neighborhood? And we only had about 50% of participants across countries that said they lived in a close-knit neighborhood. And the lack of neighborhood cohesion was particularly stark in France and in the US. We also asked participants about their financial assets, so I'll provide a few examples of the financial assets that we asked about. The first one was asking participants about their household financial situation compared to a year ago. And we asked this metric because it will help us understand social stability as well as fluctuations over time when it comes to financial stability within a household. We found that slightly more than a third of participants said they were financially better this year compared to last year, but also that this sentiment was significantly different across countries, with only 15% of people in France and Turkey saying that they're feeling much better this year compared to last year. Another question about financial assets was whether people worried about not having enough food in their household over the past month, and we found about a third of participants said that they had some level of worry about actually having adequate food for them and their families over the past month, with the number going up to 50% in the Philippines and in Nigeria. We then asked participants looking ahead whether they expect experiencing hardship in their daily life over the next month, focusing mostly on adequacy, on whether they have access to adequate food, whether they would experience food insecurity, and whether they would have available and adequate housing for them. And about a fifth of participants across all countries said that they will likely have or will likely experience hardship over the next month, including inadequate housing or food insecurity. And this really underscores the persistent vulnerabilities that many households experience across countries. We also asked a few questions about physical assets, and this is one of the examples of the questions that we asked when it comes to physical assets. So this is really about housing conditions. So we asked participants whether they experienced extreme temperature in a house for more than 24 hours over the past month. That could include extremely hot or extremely cold temperature. And we had about half of the participants across all countries saying that they experienced extreme temperature, and the number rose to 60% in Brazil, Indonesia, and Turkey. Now, these were a few examples around core assets, or as I said, when we usually think about social determinants of health, we think about those. However, we also wanted to highlight that there is another way to think about social determinants of health, and that's really your perceived social status. So we asked participants questions about their perception of economic equality within a country, and their perceptions about optimism about the future, and how those really then shape the political determinants of health, particularly in a world that is increasingly showing interest in populism and polarization within countries and across countries. So one example of the questions that we asked is perceptions about the economic opportunity with their countries. And we asked participants to rank their perception of economic opportunity from 0 to 10. And the results really varied across countries. So the results range from more than 50% of participants in India saying that their country is very equal, so 10, but they also had a significant proportion of people in India saying the country is very unequal, so about 25%, so it's really stark differences within the population of India. We also had more than 50% of people in Nigeria and Turkey saying that their country is very unequal. Now, this is important because our survey aims to assess whether inequities in social determinants of health shape perceptions about society. And here, this is just one example of those analyses. We show that regardless of the country, your participants reported that they experience more food insecurity, were more likely to think that their economic opportunity in their country is very unequal. Another question we asked participants is whether they were optimistic about their country for the next 5 years. And about 40% thought that the country will be worse off in the next 5 years. And the percentage increased to more than 50% in France, Turkey, and the United States. Another area we really discussed at first, but then we realized this is important in including in future surveys about the social determinants of health, is trust. And this is really important because trust is continuing to gain traction in global health, and it's important in shaping health outcomes, particularly following the COVID-19 pandemic. So we surveyed participants about their level of trust in governments and other institutions, and whether those align with recent literature that show that there is an erosion of trust in different institutions. For example, here we found that only 1/3 of participants indicated that they trust their government across the sample, but more than 50% of participants indicated that they have some level of distrust in their government in Brazil, France, Nigeria, and the United States. We also see that the erosion of trust currently plays out in different countries, especially what we're seeing happening right now in the US. For example, the US had the lowest proportion of people who said they completely trust their government. Again, we cannot think about trust without thinking about the core assets that contribute to the social determinants of health. So we conducted this analysis that shows, regardless of the country itself, the level of trust in government was significantly higher among participants who said they already live in a close-knit neighborhood. Finally, there are several mechanisms through which the social determinants of health manifest as forces that affect our health. Here, I will present 2 of those mechanisms: traumatic events and life stressors. Also, by way of illustration, we're going to provide a few examples of mental health outcomes and how those relate to social determinants of health, as well as the mechanisms of trauma and life stressors as ways of how those social determinants of health manifest when it comes to our health outcomes. So we asked participants about experiencing a traumatic event in their life. The list of traumatic events was retrieved from a list of validated surveys on what is considered a life traumatic event. And the list ranged from living or being in a war or conflict zone to the loss of a child or a loved one. And in most countries, about 5% of participants experienced a recent traumatic event, and the prevalence was largely comparable across countries. However, natural disasters stood out as an event that affected a sizable proportion of the population, particularly in Indonesia, the Philippines, and in Turkey. The second traumatic event that we saw a really sizable proportion in was actually the loss of a loved person, or grief, which is rarely something that we speak about when we talk about the social determinants of health and their impact on health outcomes. Experiences of life stressors, on the other hand, differed substantially across countries. So one of those results that really stands out here is that at least 30% of participants in every country, except India, said that they feel lonely. We think this is a really important area to continue to monitor, given that we see more and more evidence about the importance of loneliness as the social determinants of health, especially in an aging global population. Now, we also used, as I mentioned earlier, validated surveys to try to really look into tools that assess different health indicators, including mental health outcomes. And one of the mental health outcomes we assessed was probable depression, and we found that about 20% of participants in our pool actually reached the threshold for depression. Now, again, the influence of social determinants of health is pervasive. For example, when we stratified the data using the food insecurity social determinants of health question, we found that the prevalence, regardless of the country, the prevalence of depression was more than twice the prevalence among those who were food insecure compared to those who were food secure or those who had never experienced food insecurity. This just really highlights how social determinants of health operate to impact health outcomes. These slides also highlight that traumatic events serve as a mechanism that lead to poor mental health outcomes in every country worldwide. For example, we found that participants who experienced any type of traumatic event had a much higher prevalence of depression compared to participants who did not experience that traumatic event. Now, I just wanted to end by highlighting that the growing climate change crisis warrants more focus on measuring and tackling those social determinants of health. When we talk about climate change, we usually talk about its direct impact on health outcomes, focusing on infectious diseases or vector virology, but not really focusing on the social determinants of health. However, I would argue that the greater impact of climate change is going to come from its impact on water supply, food supply, as well as environmental degradation that leads to job loss, forced migration, and conflict, among other factors that affect the social determinants of health. So the few key takeaways I have is that inequities in social determinants of health are universal. These determinants of health influence trust, as well as optimism about the future, as well as mental health outcomes. That social stressors and traumas are really modifiable mechanisms of how social determinants of health impact health outcomes, and that climate change is likely to exacerbate those inequities. Thank you for your attention, and looking forward to the panel discussion. Can I take this? Oh, sure. A lot of.
Thank you, Dr. Bella. If I can ask the panelists to join us on stage. So we've asked, we have a distinguished group of panelists from countries all over the world, and we've asked the panelists to offer some reflections, less reaction to the slides, but more reflections about how we think about measuring social determinants to the end of informing decision-making for health. And maybe I'm going to start this way, and we'll start from Lois Pace, who is the Assistant Secretary for Global Affairs at the U.S. Department of Health and Human Services. Lois.
I didn't didn't hear the question because I was applauding this presentation, but I am also a representative of government in which people clearly in my country have very little trust, so I just want to acknowledge that. Hopefully I don't take that too personally, but I'm happy to reflect on what I saw just now.
Please do.
Okay, great, yes, that was part of my reflection, honestly. You know, I have to give homage to Dr. Kamara Jones, who really is just a dean in this area of work, and would be the first to not just acknowledge what we saw here and probably say she's not at all surprised, but to make sure we are all tracking that this is the way that these issues play out in reality is that they both hurt individuals who face these circumstances or barriers, and they help others who don't have to face them. So that play is important, I think, to keep in mind, because it's not just sort of this static, oh, this is too bad, but it's a, wow, the longer this lasts, the wider this gap becomes across communities. I'll just say a couple things, if I may, just because I don't know if everyone's tracking. The White House actually released a playbook on social determinants of health at the end of last year. And that is newsworthy, I think, because you do have a government that is not afraid to talk about everything from structural racism to wraparound services within various sectors. And I think all of us who work in this space and who just live as human beings know that you know, individuals and communities require that level of attention. Our playbook is quite focused, first and foremost, on data and the need for interoperable, integrated data, and then secondly, looking at flexible funding and ways to remove barriers for organizations, particularly backbone organizations, to show up for communities. I think the last reflection I have and will share is this is absolutely bringing home for me why I am not just representing the Department of Health, but the Department of Health and Human Services. And that's why we have an Office of Refugee Resettlement. That's why we have an Administration for Children and Families. That's why we have all of these other pieces to what we do. And I'll make it personal, right? I grew up in the inner city, where we had air pollution and other elements that affected my health. I grew up in a food desert. I lived in a foster home growing up, which a lot of people don't know, right? So there are a lot of issues that required that I stayed healthy, and it wasn't just a matter of making sure I exercised or went to the doctor or the school nurse. So I very much appreciate you including the U.S. in this, frankly, and just inviting me to be here with you today.
Thank you. Now we're going to move on to Kuman and Rasanathan, who I introduced earlier, is the Executive Director of the Alliance for Health Policy and Systems Research. Kuman.
Good evening, everyone, and firstly, congratulations, Alma and Sandro. It's a really impressive analysis and resource, and congratulations, Naveen, for the Foundation for funding this. My first reaction to this is that the great Amartya Sen, who was a commissioner on the Commission on Social Determinants of Health for WHO from 2005 to 8, he had a collection of essays called The Argumentative Indian. But if today he was writing it, clearly from this data, he should term it the optimistic India, because Indians seem to be particularly happy in this survey. I think on the question of how do social determinants of health shape health and health equity, I think as you people have already said, it's very clear, and we've been talking about this for a very long time, whether it's Virchow in the 1840s or McEwen, whether you agree with his final conclusions in the 1950s, to Marmot in the 1980s. Our Latin American friends have their tradition of social medicine. Indigenous peoples have been talking about this for a very long time. The great Kamara Jones, who we are both lucky at the moment to be engaging with a bit. So we kind of all know this, but as Salma says, we've got to the stage where governments now at the World Health Assembly all at least say they're supportive of WHO and the work that Etienne and Sudhir and others are leading, working on this, which is a big difference to 2008, where many governments were actively antagonistic. Guto, you remember. Yeah. But the problem is that we just get stuck in talking about social determinants in the introduction. We must address the social determinants of health. Whereas when you go to the budget, or when you go to the indicators, it sort of gets lost a bit. And all of our institutions struggle with that, I think. It's wonderful to hear that the US is moving on that, but there are real challenges of distilling that from a goodwill at federal level through to a very diverse and, dare I say, sort of heterogeneous country, right? So the question then is, how do we move to action? And I think this is still a major challenge, because there are definitely things we can do better in the practice of social determinants of health. And at the Alliance, we feel, in collaboration with Etienne and the team, that we can do research better, that we can act more, we can do more policy and systems research. There's ways we can engage, there are tactics we can use, but there are immense political interests that are arraigned against us moving on this. The human condition is perhaps naturally inequitable and hierarchical, and that's very hard to move against. And so it's interesting to see, well, what are the moments when societies can become more equitable, can summon the will to act on social determinants? And historically, that often seems to be in times of great disruption. We often talk about the Depression, we talk about World War II, we talk about post-independence movements. You know, my origins are in Sri Lanka. If you look at when Sri Lanka made investments in social determinants in the 1950s and 60s, it was a very optimistic period post-independence. New Zealand, where I grew up, in the aftermath of the Great Depression, built a welfare state. So sometimes crises can move us in the right direction, but sometimes crises can entrench existing interests. I think measurement has a lot to add, and I think what you've done here is a great addition. We often say what measures gets done, but that's clearly only half of the story. Measurement is necessary but not sufficient, because in many countries we've been measuring health inequities for a long time, and they just get wider, including some of these countries. So, but I am optimistic, and I'm sure Jeanette and Guto will talk about the very impressive things that are happening in Chile and Brazil, in your decentralized state, in Indonesia, Dia, and I'm sure Blessing as well. So it does seem, with the digitalization reaching a critical mass, the promise of AI, the ability to get much granular data, even what you've done, but can we get this sort of data on a regular basis? And some of the things, I won't steal your thunder, Jeanette, that we were seeing in Chile in December, really point to that. My friends in the Social Determinants Department have recently released an operational framework on monitoring the social determinants of health equity, and that actually talks us through the processes that countries are doing and can do, so that measurement leads to results and data, but leads to action. And I'm sure Etienne will talk more about that. So this is great, but we need to use the sort of imperative of increasing inequity, the promise of our digitalization, to get the disaggregated data, not just result on externally funded surveys like DHS, have the joined up data across sectors, but really meet people in their realities, and then not just collect data, but actually act on it. And that, as hard as measurement is the even greater challenge.
Thank you. We'll next go to Dia Seminarse, founder, CEO of the Center for Indonesia's Strategic Development Initiatives. Dia.
Thank you. Checking whether this... Oh.
Yeah, we can hear you.
I would arrive back at the point of data that Kumanan just ended on. But I would like also to give an overview of how complex and diverse Indonesia is. It still has a very high maternal mortality rate, which has been the center and the focus of so many interventions, but still the progress has stalled. And the answer to the why is that the social determinants aspect surrounding death of a mother, death of newborn. And sadly, it's not just at some remote corner of Indonesia, it's also at the very center of urban Indonesia. Indonesia is like high-income countries, low-income countries, least developed countries, all integrated into one. And it's that the consequences of that is we have very high variation of results in urban settings, in rural settings. And I think what we found out through our work is that relies upon health facilities, community health workers, and also health professionals to do not only health intervention, but beyond health intervention. giving education and also answering to educational issues and aspects, which then bring towards improvement of the health dashboard. But that being said, people are so busy doing interventions and correcting the health dashboard that they forget data needs to be collected, data needs to be governed, and then be made available in order to achieve actual progress. So I think that's the path that Indonesia is in right now, transforming the health system, doing a systems approach. That's the result that we see. Because when I see your results, the first thing that came to mind was, from which part of Indonesia is this? Because it's, like Kumanan said, it's a decentralized country. Progress depends a lot on a decentralized leader, not as much as on the national level. So I think it's will be very interesting to find out over the years that we can see more of the connection between actions on the ground by the communities, and then how we then connect that to the available data sets that we need to measure. Thank you.
Thank you. Next, we're going to go to Janet Vegas, a former Minister of Social Development and currently Senior Advisor to Minister of Health in Chile. Janet.
Thank you, and congratulations for the work. So I'm going to focus on the data related to social determinants of health. And I think that we have two main challenges right now related to data. The first one is, how do we enhance the accessibility and use of social determinants of health data? And the second one is, how do we advance in measuring solutions, which is not usually a measure. So in terms of how do we advance the use and accessibility of data, we have a lot of challenges. The first one, of course, is that in almost all countries, social determinants of health data are collected, but are collected in different sectors and multiple levels. So we have data from different sectors and multiple levels: clinical data, electronic records, for example, health system data, other social systems data, and community and networks data. But also, these data are in some parts global, national, local, and individuals. So we need to have, there is a need to link the individuals and population data. And in our experience, if we really want to address the issues related to social determinants, and in our experiences, one definition that is critical is to define population and individual data by geography, by adequate geographies. Because that's a nice entry point for action. Now, we know that there are significant variations, and you alluded to that, in data collection, sharing, and use of the data. So we really need to develop some standards for social determinants of health data. And also, we know that there is not clear connection between the social determinants of health data and the policies to address them. One of the issues is that when we were working on the Commission on Social Determinants of Health, developed a very nice framework that explained the different determinants and then basically sort of the framework. But we didn't develop a similar framework for successful interventions to address social determinants of health at each level. And that is really needed. And also, the other thing that was also alluded here is that data usually do not include community assets and resources. So we never map community assets and resources. So we assume that the populations and communities are waiting for us to basically to let them what to do. So in summary, I believe that in order to address social determinants of health and improve health equity, we basically need to first make sure that we improve data infrastructure and high-quality data collection. Data infrastructure is important, and it's lagging in several countries. Secondly, that we need to link individual and population data, and I would argue that the level of analysis is geographical. Third, we need to develop guidelines, as I said before, to basically make sure that we know and we share good experiences, proof of concept experiences. And in particular, I think that one low-hanging fruit is the connection between health and social services intervention. And what someone called this integrated care, not integrated health care. And there are some countries such as in Catalonia in Spain that are really advanced in these areas. And also we need to understand how do we include the families and individuals that are affected both in data collection, policy making processes, which is basically how do we contrast our findings and recommendations with the real world. I don't have the time to basically to show you how are we advancing in my country on that, but I'm happy to talk to anyone that is interested after the session. Thank you.
Thank you, Jeanette. Now we're going to go to Luis Augusto Gunter Galvao from Fiocruz in Brazil. Gunter.
Thank you very much. So it's glad to be here among old friends. I think a year ago we were in social determinants, but that was indigenous people declarations, resolution. That's yeah. We keep in the same area and trying to advance this. I think social determinants of health is very important because we review the 80% that Naveen just mentioned here. So I will give an example. We have a Center for Integration and Analysis of Data from Fiocruz in Salvador, Bahia. And they analyze, they receive everyday data from social, health, economic, by people when they integrate that. And we analyze the consequence of the cash transfer of Brazil program in health. And they find a very interesting results. In adults between 14 years old and 45 years old, the cash transfer was preventing 53% of the suicides at that level. 53% prevention is much higher than vaccine prevention. So review this effect of the social determinants. And that, I think, is a very central to working social determinants, because that can review that part of public health you don't see, is the phantom of public health. So it's the one that actually construct everything we have in terms of health, and nobody see it. We only see, as Naveen say, the health services, which of course is very important too, so nobody's have any doubt in that. The second part of social determinants is a passionate thing. So my thesis in the 85, the name of my thesis is Where We Work, Where We Live, and Where We Play is Good for Health. That's the thesis, my very, master of the degree C. And then, we, Jeanette, and with Kumamanan, we work all these years on that. I am part of the regional network, America's Network for Health Equity. It's still very active. The Rocio, or leader in Costa Rica, we still work on that. So social determinants of health bring people together. I read the goldfish column from Galea every week, and that's interesting and very inspiring, this passion for making the social justice happening. And I think that's another very important contribution of social determinants of health for public health. Bring this to the real scenario, so bring this to alive, it's not only something when talk about, systemic racism or whatever. This is a very important bring people together. And the third one is about data. So I don't want to go, I think Jeanette covered that very well, but I want to say it's very important to bring the data, but it's very important also to give more credit for the data we don't have it. Most of the data we have is actually from the academic world. Academic world we know is elite. So we need to bring people and the data from the people to the scene. So today in Brazil, we are working actually in popular surveillance and bringing, the population at the scene and that have a voice and have been reflected in the whole health system. Minister Nisia established a special advisory only for population engagement, and they are mapping everything in the country, every social movement, and bring that together with the health services at very local level. At least, now in the flooding, we have this very sad flooding in the south of Brazil. Historically, we have 500,000 people out. We lose 4 cities, entire cities. My son works in an insurance company. He has to recover 15,000 cars. So just to give you an idea of the dimension of that. We lose all the industry, we lose many, many things. There's billions of dollars of things there. It's similar for New Orleans, and very sad about that. But that one of the things is happening now is that we have this mapping done. So we are much easier to work with that and to recover the social determinants of health based on the data. And I just learned Jeanette is doing something similar in Chile, and we will exchange some of this information. Thank you very much.
Thank you. And now we're going to go to Blessing Mberu, who is the Head of Urbanization and Wellbeing at the African Population and Health Research Center. Blessing.
Thank you. And thanks everyone for coming. It's a privilege to speak last because everyone reminds you what you've been thinking about. But I'm also happy, Salma, to see Nigeria there. We used to be the happiest people on earth. I think we are losing our spot. So, but yes, I wanted to talk a little about, this is a great work and pushing us to think further. And I like the global dimension, but you have heard everyone say it's more complicated than that. Because if you talk about, for example, Nigeria, okay, that's the first question. Where? Southern Nigeria, Northern Nigeria, Eastern Nigeria, there's so much complications. And again, I work in Nairobi, Kenya, and we cover 54 countries. So when you hear about Africa, you say, okay, this is not actually a village. It is 54 countries, very complicated. Anglophone, Lusophone, Francophone. And so it becomes a little more complicated. And as we begin to go to data measurement, I just wanted to highlight that those are the things we need to begin to think about. But this is a great place to start. So, but let me speak a little about urban Africa, where I work. And what you see is that national data sets give you averages. So it blurs the inequities that exist between, even within a country. And if you look at a city, for instance, urban areas, you have these urban averages, okay? But if you come to an urban area, for instance, you see a lot of informal settlements across urban Africa where I work, and I'm sure it's the same for many parts of the global south, probably in the north, as we know about the US and what's going on there. So most of the time you lose the major segment of the population, the marginalized, and sometimes, like for example in urban Africa, some of them constitute the majority of the population. So if you're going to talk about social determinants of health, then these are places we're actually supposed to continue to look at, make investments in. Okay, often data is not disaggregated, and I think it has come up here. Okay, so that, and yet you need disaggregated data at the local context. You talk about devolution, where power is devolved. It also came up. Okay, in Nigeria you have states, you have local governments. In Kenya you have a devolved system. So the health is devolved between the national, okay, and the local governments. And many of the challenges we are looking at reside at those levels. okay? That is where local governments, implementing agencies need local context, local specific data to make decisions, okay? To evaluate, define even priorities, okay? It's just like when we talk about climate change. It's a global phenomenon, but it has local meaning. And what does climate change mean for a local farmer in somewhere in Turkana because of the complexity of the issue? So I want to highlight that that's what we see, that investment in this local context, specific data will be very critical. When you talk about social determinants, many of the time the data is not quantitative. And you alluded to that. Many of those data are qualitative. And so you need qualitative data. And what do we see? It's not there. It's not a reckoning, even when we recognize that. Okay, I'm a demographer, so I like quantitative data. It makes my life easy. But if you go on the ground, you need qualitative data to understand the hows and the whys if you're really going to address it. And you've had a lot of what's the feedback loop to policy and to action, because that's where the issue is, okay? Finally, maybe not even finally, there's something about Africa I have not keep hearing. The fact that you're able to do this, Salma, and Boston University, the critical mass of researchers and skill you need for data collection, data analysis, interpretation, okay, converting complex models to understandable narratives is still lacking. So we need a lot of investment. Sandro, as you move around, we still need opportunities for masters and PhDs in this area so that we have a critical mass of people. And there's also a new phenomenon I want to highlight. That's the growing linkage of data to national security. In Kenya, it's almost becoming difficult to just do the research. Okay, there is all those controls. I don't know about other countries, but it's, so that you have a lot of data protection legislation. And so when you talk about sharing data, access to data, it's not as easy as that. There are a lot of local challenges. And I want to quickly give example of Nairobi, Kenya, where I work. It typifies African urban crisis and the whole challenge around data. And what you see there is that 5% growth rate for informal settlements in the city. So when you come to Nairobi, you will see the first ward, the second ward, as you move from one neighborhood to the other. Okay? 5% growth rate in the slums. And these are areas characterized by critical social determinants indicators, which includes like limited access to water and sanitation, overcrowding and poor housing conditions, limited employment opportunities, and the near absence of the public sector. It's like you're on your own. You are your own government, and yet you are in the city. So these are challenges I wanted to highlight. Just to conclude, I thought I just have 2 more points, Sandro, and that is the absolute number of slum dwellers, the marginalized, the vulnerable, will continue to grow. It will continue to grow, so we need sustained investment. And this, I said, is a move in the right direction. Particularly how do we address the marginalized, the vulnerable, because that is very critical if we are going to actually make advocacy that actually speaks to people. So, providing municipalities, local governments, city managers, data that helps them, granular data, and I've had it here, that helps them prioritize interventions, that helps monitor and evaluation. Okay? If you look at DHS, for instance, it's still, first of all, it comes 4 years and so on, and a lot of changes happen. So I really want to highlight the fact that there is a lot of complexities. Our work is cut out for us. And I think I'm happy that I was wondering where I met him. It was 3D Commission. And the 3D Commission and the group are still determined to keep pushing this agenda because we need data. But we also need it timely, but we need it to incorporate the complexities that exist in many cities and around the world. Thank you.
So I'm going to ask just a couple of questions of the panel, and then I'm going to open it up to the audience for about 15 minutes of questions. So just priming the audience so you can get rid of your questions. I'm going to pick up on something that Kumanan said, which is that in times of great disruption, there's moments of opportunity. There's obviously moments of peril as well. But accepting perhaps as part of our common understanding that we are in a time of great disruption in many countries and globally, so there are opportunities. Given the challenges and the sort of the slow evolution of social determinants as an agenda and the challenges of moving from abstraction to concrete action, I'm actually curious what the panelists see as just one opportunity in the moment around advancing this agenda. If I can force each panelist to say one opportunity to advance this agenda in this moment in time in history. I'm going to get comments from everybody, but anybody can jump in. Janet, go ahead.
Yeah, well, I think I said it. For me, a low-hanging fruit right now is to basically to advance in connecting social and health services and care. That, I think, is a huge opportunity in most of the countries.
So there is actually a literature looking at crises and in which circumstances do crises lead to positive change and to negative change. And admittedly, I don't think it's an authoritative science, but essentially it seems that if crises are seen as having a clear reason, then the question is, where is blame directed? And if blame is directed in a way that then leads to the greater possibilities for alternative ways of organizing societies, you can move in that direction, right? So I think you can imagine in the Depression, really people, the economy failed, people were homeless, people were really desperate. And so that sort of challenged some of the existing order, and the blame was very much put on certain sectors of society, opened the space for welfare states, for greater union rights, not in all of the world, right? But if you look at the global financial crisis in the late 2000s, which was a major disruption, it didn't really lead to a major reordering. There's a real resilience in the existing system, right? So I suppose the question is that firstly, what is the extent of disruption in our societies? And again, what is the narrative around what's happened that might lead to new opportunities? And I think at the moment, I mean, it's with the challenges we're having, the challenges of polarization and fragmentation, the isolation, the disinformation, it seems hard to see how we might direct these disruptions to some of these alternative opportunities. But my wife always says I'm pathologically optimistic. Must be people from origins in our region seem to be very optimistic people. So there's these two grand transformative forces of digitalization and decarbonization, right? And I always say, digitalization in the health sector hasn't done very much. The two most sort of institutions in our society most resistant to change, I think, are the health sector and the academy. So we're all complicit. And the way that people get care is still very similar to the way it has happened for many decades. The way we sort of teach is often very similar. But finally, the technology is at such a critical mass that it could really disrupt that, and it can disrupt what we know about people and the way we can harness data. But that could go, I was talking to this 26-year-old guy who works at OpenAI a couple of weeks ago. And, they've got a team thinking about what to do on health, right? But of course, people have justifiable concerns about the hallucination. They have concerns about the concentration of IP in a few corporations. So the question is, can we steer this force, which is really transforming our society? It is going to transform healthcare. It's going to transform the way we track people through society, the way we deliver health and social services. Can we steer that in a way that really addresses social determinants and improves equity? It's an open question, but there's definitely a possibility there. And then the second one is the decarbonization. And on the one hand, you have countries saying, wow, we're going to lose whole industries and we're worried we're not competitive, so we have to be more protectionist to maintain. On the other hand, it does promise a sort of energy boom that can open up services to whole communities that have never had them in the way that whole communities never had a fixed line telephone, right? So I think, I'm not sure if I'm sure it'll work, but there are those two opportunities to steward those two forces in a way that takes account of the social determinants, improves the social determinants, and improves health equity.
Lois.
Forgive me because I'm afraid, you never want to follow Kumanan. But I'm afraid I'll offer just a more basic example. I mean, look, I think we still need to talk about the COVID pandemic as much as people would like to move on. And I can hear a lot of people saying, yeah, but did that work to wake us up? Not entirely, clearly, otherwise it would have gone a lot better. And yet, hear me out, I am able to have very different conversations within government because it's undeniable the ways that social determinants from the individual and truly up through the systemic level played a role in those inequities that were just so glaring. And it has, you know, in a week and at a time when we're all, maybe not all of us, but many of us are wondering whether countries will come through with real action to make it right. I know that many of us around that table have been at the table and stayed at the table because of that disruptive event. And not just because it was really bad and we lost a lot of lives and all of the terrible things that happened, but because it was so obvious and shameful and tragic how preventable it was because of these external factors, these factors external to health. Can we and will we solve all of those problems? No, because that's not how this works. For those of us working in this space for a long time, that's never how it's been. And there are earnest efforts, I will say, and I am also an optimist, to acknowledge these not even underlying factors, right? These overlying factors and these fundamental considerations to say, hey, we have to take a much closer look at the issues beyond health that will drive health and protect, if not improve it.
Yeah.
I would like to build on what you point out, Lois, as and fill it further. Yes, pandemic, but what did the pandemic leave us with besides the destruction? I think it's also the pandemic left us with scattered, albeit scattered, community-based data, availability of community-based data. So that can be made into an opportunity to address the social and health intersection, the social, health, and climate intersections if we layer it with a lens of gender, diversity, and inclusion. So I think that is an opportunity left wide open by the pandemic that is for us to fill it in with more robust data and to not stop at leaving it scattered, but how to make it into a systematic community-based data. Then it will enrich the decision-making process, it will enrich policy direction and long-term planning further at national level, but I'm sure it will somehow be brought up, can be brought up to the global level.
These are really interesting answers. Salma?
Yes, that's a difficult question. I was thinking about this because I think I fully agree with almost everyone here. I'm a big proponent of AI. I actually think I would be very helpful, generally speaking. So I like that. I'm assuming there are a few people who disagree with what Kumanan said. But what I also really like what Lewis said, because I was thinking the pandemic itself wasn't an opportunity, but I think it's just highlighted the importance of social determinants of health in a way that no one can then dispute. But I've been in meetings after, like the 2 or 3 years after, where people start the meeting with saying, oh, the social determinants of health are so important. We need to talk about solutions. And then the second session that speaks about solutions just talks about the healthcare system. And I don't think it's because people don't recognize social determinants of health are important. I just think it just feels very overwhelming and beyond what we think we can do. So maybe also I'm getting older, but I think what all of this taught me over the past few years, because I've been thinking about it, is I think this was an opportunity for us in health to think about trade-offs. how do we speak with people who can do work on social determinants of health who are not in the healthcare sector? So instead, we were having conversations earlier. So thinking more about how we convince people beyond the health argument or beyond the moral argument why it's important for them to care about the social determinants of health. And I think the pandemic actually provided a good opportunity for that, sadly. But,
So in terms of crisis and the recovering of the crisis, one thing you always say is how you can be less reactive and more proactive. So I think the crisis always brings us the opportunity to be more proactive for the next one. And particularly for the most vulnerable population, I just want to mention two, homeless and the indigenous people. So if you're looking for these two populations, they suffer the most in pandemic. They are suffering the most in the heat waves and the flooding, everything else. So how we can be more proactively and more focused on the most vulnerable population. And this is always come back, always we talk about that, but that's a good opportunity to actually, at least save lives of that people that is out there. I think this transition bond, be reactive to proactive, particularly for the vulnerable population, is essential when you talk about the unnecessary and unjust inequities that bring the social determinants of health. That's kind of thinking. And climate is one then, but I agree. Pandemics is closing in the window without the solution. So we are actually, leaving this open for the next pandemic and without actually be more proactive on that. So I agree with Lois that we need to also to, reopen that window and look for opportunities for that.
Yeah, thank you. Let me give an example of what we've done, a very good example that speaks to the spectrum of this discussion. One is how we collect data, okay, and collecting granular data. We work, Nairobi is the capital of East Africa in a way of speaking. But like I said, majority of that city is slums. So we decided to collect qualitative data on who are the most vulnerable in Nairobi. And we didn't define them. We asked the communities, and they gave us older persons, persons with disability, and children heading households. Let me go on children heading households, but can you imagine being 60 years in the slums of Nairobi with that kind of housing, very hot in the day, very cold at night? Even if they bring you free water, if they bring free water to the settlement, particularly during pandemic, you can't access it. There are thousands of kids with muscles. So the old person will not get that water. Assuming you have disability, how do you survive in this flooding? Okay, but let's go to the most vulnerable, the community identified. These are children heading households. If you live in African capitals, you drive to the traffic light and you see kids come to your window and you think they are miscreants. No, those are heads of households. They are thinking of their parents and their siblings. So that money they are begging for is actually doing what many of us do. Think about rent, think about food, and so on and so forth. And the pandemic hit them so hard because they used to go to school and at least get a meal a day. But with the pandemic, school closed. Okay? So what we saw, so that made us to look beyond Nairobi. And we saw that this is an issue in Nakuru, in Nairobi, and in Mombasa. Those are where you have prevalence of that. Okay? So what do? Now you have this data. But because it is focused on these cities, we were able to approach the Nairobi City County, okay, and say, look at what's happening here. What do you want to do about it? They say, oh, we have a policy going on. We say, well, this policy process, I'm sure you know how long it takes. This problem cannot wait. So eventually we were able to get into the youth caucus of the Nairobi County Assembly. And last year they passed a bill on child-headed households, speaking about all the social determinants, food, housing, training, and so on and so forth. Okay? So now that bill has been passed, and we had engagement with the executive to say, how do you put it in the budget? What programs? So we are going to continue the discussion on how do you move that policy, that bill, to actually fundable projects that will actually address some of those issues. It will not address all of it, but at least there is a start there. So our thinking, even at APHRC, is that data is great. How you collect it is also important, but more importantly, what's the feedback to government? And how does that data inform policy and action? And this one was just a very good example of how you collect data that is context-specific, relevant to the local authorities, and we are moving forward in that direction. I think for us, that's the way to go. Not that it will solve the global problem, but it will solve that problem at the local level. Thank you.
Those are really thoughtful answers. Thank you. I'm going to take 1 or 2 questions from the audience. Right here in the middle. There's a mic coming.
Hi, thank you, everyone. My name is Dr. Kechi Achebe. I'm the director of the Office of Global Health at Peace Corps. Been in preventive medicine, public health for over 25 years, and a proud alumni of Boston University School of Public Health. So it's really great to see the work that you're doing. And, you know, I have many questions, but I will keep it to one.
Just one.
Yeah.
Just one.
I think because the panel, you know, different, all of you have touched a little bit of what I want to say. Professor Barrow, I was like shaking my head and almost jumping out when you were speaking most of the time. I think for all of us that have been in this for a long time, you know, we know what the social determinants of health are. You just need to do a Google search or, you know, one of the searches, and you would see it's flooded with papers that have been published, you know, and the data there. So it's good to add this, but there's so much out there. I think what is missing is how that is used to inform decision making. I think someone alluded to it, that we a lot of times keep it and keep that to either the you know, tertiary institutions or the health sector. The decision makers are not in the health sector. So how do we use this data, and how do we socialize this data so the people making the decisions, the Congress, the ministries of finance, are the ones that use this data, are being invited at the beginning, not at the end. I think it's something that we really need to look at, and that's what we need to move. The data is out there already.
Maybe Dia, I'll ask you to comment on this, please. You referred to this in your comment.
Yeah. In Indonesia, I can give you an example of what the government in Indonesia has done since, I believe, 2017, 2018. There is this approach called, it is basically health in all policy. We term it in a different language, of course, but it's basically health in all policy, where health is expected to be budgeted in different ministries. That took off 2017, now I remember it's 2017. However, the flaw in that setup, in that planning, is that it includes all the ministries but not other development actors. So it's as if it's owned by government only, while it actually has to be owned by everyone, and then being taken from planning into action by multiple development actors. But the foundations are there, and right now Indonesia is embedding health in all policy in our long-term planning, so it will extend into 2045. At least in the medium-term planning, it's already there as well. So let's hope that the second time around, this attempt will work better, will have more civil society and other private sector, academia also chipping in into ensuring the success of health in all policy.
Jeanette?
Yes, I wanted to provide a different example. In my country, we are sort of doing things the other way. So we are basically creating a unique window for people to go at the municipal level, and basically we use integrated data. We have integrated all the data sources in the country, but not integrating the data on social determinants, but integrating the data on social and health services. So basically what we have now is that for every sort of geography, in our case, the geography are the neighborhoods and the countries. If you go to your municipality to request anything, the person that is the first person that takes you have in their screen all the data from you and your family, including services, including subsidies, including some health alarms that we have put if you are going to your preventive services and so on, and including all data related to community assets and resources that you can use in your neighborhood. So when you go there, at the same time that you get the service that you are basically asking for, you get additional services that are proactively given. For example, I go there and when to basically to get some of the monetary subsidies, but then the person that is there basically say, you know, it's very good, but you haven't had your preventive screening, so let me refer you to the people, and then the referral is internal, and then the health teams, if the person doesn't show up, go to get them and capture them back to the services. And in addition to that, what I think is quite interesting is that we have done mapping of community resources with the communities, and in charge of that are mixed teams of social and health teams that basically walk through the communities and meet with the communities and map these resources. And that mapping, of course, we basically geolocalize them. So when you go, also you get your map of resources available, either infrastructure and others, such as classes and all of that. And of course we map everything else geographically. So you have the maps in each community regarding most of the social determinants, but most of the benefits and also the main issues related to health impact.
We could spend 20 minutes on every answer, but I'm going to take one more question, then we're going to move to closing remarks. Right there.
Thank you very much. My name is Kennedy Wakoli from Amref Health Africa in Kenya. I'm based in Nairobi. Thank you very much for highlighting Nairobi's situation. I've just been reflecting as the discussions have been going on that we may not achieve our SDG targets, and the only reason that will make us not achieve those targets are social determinants. Amref Health Africa has invested a lot of our resources in health in the countries that we support, but we've seen very little progress. And that's why in our new strategy, we have intentionally focused on social determinants of health as a key strategic focus areas for our health interventions. And I'm asking, just a follow-on on what the presenter of the research shared. These social determinants are basically not within the confines of health. We have very little control on those social determinants because education is a full-flown area. Climate change is a full-flown and not being handled within the health sector. So what should be our role? What should define our role as health, as a health sector towards addressing those social determinants of health? Because when they occur, like 2-3 weeks ago, Nairobi was flooded, Kenya was flooded, and we had a worst, it was all over the media. We had the worst flooding ever experienced in the country. The health system was almost collapsing. So what we suggested is that, are we able to build a resilient or adaptable health systems as part of our contribution towards addressing social determinants of health? Are we able to ensure that our communities are able to make informed decisions as a way of handling education as a social determinant of health, so they're able to make informed decisions regarding their health? Are we able to see our communities having sort of sustainable livelihoods towards ensuring that they're able to finance their health issues. So the question to the panelists, what is the best way in which the health sector can address these social determinants of health, given that we have very little resources or very little power to galvanize all these four together, in as much as we are part of those intersectoral committees, intersectoral boards that are formed. Then the last one is a challenge. Given that this is a very timely discussion, is it maybe time from Boston University, given that you've shared those studies, to form a collaborative that regions can learn? Because when you're talking about inequities, it has really been demonstrated that, and it made me reflect, I thought wealth is health. But now when we have countries that are wealthy also have inequities and placing social determinants so at that level, then it makes me reflect otherwise. Is it time that we form a collaborative as part of this session that can easily track and support countries on how to address social determinants of health moving into the future? Thank you.
So let me address the last one, then I'm going to go to the panel for a lightning round answering your first question. On the collaborative, I think there is no better time to do that. And actually, I'm going to ask for closing remarks from Dr. Etienne Krug. One of the conversations we're having is actually trying to build such collaboratives and such infrastructure. Maybe to ask the panel to address the question, which is, what is the one thing that we in the health sector can do today to actually infuse social determinants thinking in all other sectors to make it clear that social determinants matter for health? And we'll just go around very quickly. Selma.
Sure. Maybe a simple and too basic, maybe, but I think I get asked by my students, because I teach social determinants of health in the master's program, and I say, if you really want to improve health outcomes, do not work in a health department after you graduate. Work in a transportation department, work in an education department, that you bring then a health lens to the conversation, and instead of just continuing to work within the healthcare sector. And I mostly say this because I think multiple people said this, we keep having the same conversation about how important social determinants of health are important within healthcare. I think we need to move beyond that. So I guess I'll say the same advice. If you're really interested in shaping the social determinants of health, I think it's time for us to actually work in different sectors. Yeah.
Lois.
Same. Also, I don't know, work in government. Build the trust and make a difference. And apologies, I have to run off because people are waiting on me, but appreciate being here.
Thank you. Come on.
I think the short answer is that we in the health sector just need to do our job better, because I think it is actually clear what our contribution is on social determinants of health. We've talked about it for a very long time. When we developed the health SDGs, we framed and we said that health is a prerequisite, an indicator, and an outcome of development, right? And that is the framing of the SDGs, but we haven't managed to really integrate that thinking into the way that we do our work, and we need to do our job better. And as the health sector, that's essentially three things. The health sector is a social determinant, and so we need to make sure that we don't exacerbate inequities, and we structure ourselves to do our own job, and that's delivering healthcare and developing policies. Secondly, we have a role, and we are custodian, as you have contributed to, on the measurement and the monitoring. I mean, who else is going to measure health and health inequities and link social factors to health better than the health sector? But the third one is where we really fall down on. The other two we are getting better, which is our role, our limited role in stewarding and catalyzing action across society on social determinants, being humble, realizing our limitations. And our big challenge is that we continue to have discussions on social determinants among health people about what the other sectors should do. And we really find that a challenge, but there are collaboratives. Nicole's in the audience. She coordinates a special initiative at WHO on social determinants with a number of countries. So there's progress. There are countries in the initiative are moving, but we still really struggle with this, the social determinants, the language, the interest. We're not engaging with the interests of the other sector, why they might engage with us. There are some very good examples, but overall, we just need to do our job better.
I think it's embracing diversity. When we work in the health sector, we tend to think that if you want to be heard or you would like to have a voice, then it's either you work as government or you work as someone in the international or multilateral organization in health. I think there are groups or population groups within the health sector that needs to embed variety into the health sector thinking, like you said, but not too far from of the health sector, still in the health sector, but take a role as civil society, for example, and then present a different perspective and different point of view, which is somewhat missing. Take a role as an academics. In Indonesia, we still need public health academics and researchers. So take a position and be aware that your position is actually enriching the conversation. It's good if you have diversity in your background, so not only health, but I think in general, health sector cannot be governed only by government. Health sector needs to be governed by different actors within the health sector itself.
Yeah. Well, I'm going to say two things. One is basically, instead of talking about health in all policies, let's talk about health with all policies. I think that in my experience, at least, the most difficult change is to change the mind of the health people. In most of the times, the other sectors work much more together than we work. And when we say health in all policies, we're basically saying everybody should take health into their own policies. Why? Why is that? Why is health more important? So I would say instead of that, we need to basically have a different target, which is basically well-being. And well-being is not only a health issue. So I do think that there has to be a shift in the way that we in the health sector think about action in social determinants. We need to incorporate us to the other sectors. And then just a quick response to one of the questions. There is a special initiative in WHO that is basically working with countries specifically on that, on how do we advance solutions, how do we basically walk the talk. And I would recommend you that you can get more information. In fact, one of the leaders of that initiative is in the room right now, Nicole. So it is a very nice initiative to participate on. Thank you.
Yeah, there are these health in all policies inspirational principle, but at the same time, you know, when you talk about that, people say, oh, here's come the king of the all sectors, is health, you want to give and govern all the sectors, and then that doesn't work. So I think you're totally right. You need to have another way of doing business in terms of engaging other. And for me, one important point is education. So the other sectors should embrace the idea of health and understand the consequence of what they do for health. That would be essential in terms of promoting not the idea of health in all policies, but health within all policies or within all the disciplines. That, I think, is an essential role. There are also other opportunities today. Digital health is really very important. NISA created digital health, the one vice minister on digital health. And one of the most important part of that is fake news. Fake news is always, and the fake news today is actually one of the determinants of health, and we can act on that. So that would be one of the possibilities today to engage in that conversation and make it less damage for the population. So that's will be for me the two takes: education and digital, particularly fake news combat, which is very important in terms of the social determinants of health.
Blessing.
Thank you. Yes. Again, maybe I give our example. We have decided, and it's out of experience doing research in Africa, that you need a different approach. Co-creation, even co-definition of problems. So we normally would engage government departments, okay, as many as we think are relevant to that issue. So, so multidisciplinarity in terms of disciplines, but also transdisciplinarity in terms of not just scientists, but also actors, including communities. Okay, and I can give an example. We have a program we're calling Idea Maps integrated deprived area mapping, okay? And we use GIS, we use Earth observation to be able to map changes within Nairobi, like what has just happened. So, but for you to define what is you are really looking for, we engage the Nairobi County government, people in urban planning, UN Habitat. We have partners in AI from University of Twente and University of Glasgow, and we all gather. It's a big meeting, okay? A lot of negotiation, but if you really want this to make sense, then you better do it from the beginning. So we then finally agreed on how, what would the city need? So we are setting up a platform where we use AI technology to, to monitor changes within the city, to see what is happening, to monitor air quality, and so on. So that if you go to that platform, you can click an area within Nairobi, like Dagoretti, and say Dagoretti, level of deprivation, level of changes, and eventually you will generate a map. So it was really exciting, but there's a lot of education there. For example, and maybe you are here, you help us. What does AI mean in Swahili? So, because for the community to understand what you are talking about AI, they need to know what it means. If an issue is local, they have a name for it. If it is foreign, they have a description for it. So we ask, what is AI? If you go to Google, it says AI is fake brain in Swahili. And that's not what, I mean, how do you tell someone to talk about fake brain? So in essence, this mode of collaboration, transdisciplinary, even the people who do the mapping are from the communities. We hire young people and give them some of these technologies to be able to gather the data, to do GPS and so on and so forth. So it's a lot of work. But if you really want to have relevance of what you are collecting, relevance of that platform, anybody going to use it, then that is the process we have adopted. Transdisciplinary approach, collaboration, I mean, it's key, both from the global north and from the global south. So at the end, all of us are learning, and that synergy creates something that you are sure will have some ownership, some legacy impact. When you finish all these projects, and we are all guilty of that. We do a lot of inbreeding in academics, okay, in research, where we talk to each other, we criticize what happens, but the people you are talking to are in another world. So we are doing a lot we can to bring them in. And I think that's the way to go. It's a lot of work, but it's better than doing work that nobody uses or nobody owns. Thank you.
Thank you. I'm now going to invite Etienne Krug, Director of the Department of Social Determinants of Health at WHO, who is going to summarize and tell us what we're going to remember from today.
Do a good summary.
Thanks so much, Sandro. Good evening, colleagues and friends. Great to see all of you. Before we started this event, Sandro told me, Etienne, you're going to be the last speaker, so everybody's going to remember only what you said. He kind of astutely transformed this now into, I'm going to give a summary of the discussion, which of course I'm not going to fall into his trap. I also know that what he really meant was, Etienne, be short, everybody's tired and want to go to the reception. And I don't have much to add because we have some of the gurus of the social determinants work on this panel, and I agree with many, many of the points that were made. But let me first of all congratulate the team, Salma, Sandro, and others who worked on this important data, which was very stimulating, and I think on every slide it raised questions on, why is it that in this country there is more or less trust in government than in another country. Sorry, yeah, Lois, US wasn't faring very well on that one. Why is it that in this or that country people worry more about the future, about their financial security, etc., etc.? I was particularly pleased also that this study was based on a similar methodology used in different countries, because I think having comparable data from a series of countries helps a lot advance the thinking on this topic. And this is why, as Kumanan said, we at WHO released the framework for collecting data on social determinants of health not so long ago, at the request of the World Health Assembly. And if you have not seen it, please take a look, because it's, I think, a very important tool for all of us and countries around the world to be using for further comparable data collection. What I also liked about this event is just that it happened, and thanks for setting it up. We need more events on social determinants in margins of the World Health Assembly. I think it's a sign of the rise again of the interest on this topic, and so I'm very pleased to see this discussion happening. But I agree with what was said also by some. I want to paraphrase, but it was basically, so what? I think we want more data, and I agree also, Kumanan, it is hard to collect data, but it is even harder to use that data for action. And I think that's my challenge to you, Sandro, since you challenged me. Let's have an event next year about the so what. How can we use data for furthering decision-making, and what should be the decision-making be focusing on? I think it is time for the field of social determinants of health to narrow it down to some of the most cost-effective interventions, and we need to know what they are. So I think there is a whole research piece there thinking about best buys in the field of social determinants of health, and I hope together with the Alliance and partners we can engage in that in the years to come, because it is a much needed piece. We're doing a great job in making noise about social determinants, and there is more and more attention going to it, no doubt, including tomorrow in the WHO, if all goes well, tomorrow or Friday. It will happen anyway. There will be another discussion on the topic, looking at the recommendations of our upcoming World Report. But we're not so good yet at transforming all of this noise into concrete action at country level. And let's think about how we can do that better. For me, it's certainly trying to slice up the field and look at these best buys. Is it housing? Is it social protection? Certainly commercial determinants needs more attention, urban health. These are some of the areas where I think we can have, I was not going to say relatively easy wins. It's going to be complicated because it's a complex field, but certainly we can have some wins in those areas. And the more wins we have and the more we can advertise and show that success, the better we will fare in building up this field. So again, thanks to all for the support. Thanks, Sandro and team, for setting up this great discussion. Thanks to the great panelists. It's always a pleasure to listen to you, your passion and your knowledge. Am I really having the last word, or are you going to have the last word? I suspect you will.
I think it's you.
Yeah, okay. Go ahead. Thanks so much, Sandro.
Thank you to the panelists. Thank you to the audience in the room. There were about another 1,000 people on Zoom. I'm sorry we couldn't engage them in questions, but there was a very live conversation happening on Zoom that people in the room did not see. Thank you all for being a part of it and for giving the time to thinking about these issues. Everybody, thank you. Have a good rest of the evening.